Good morning, everybody. I'm Dr. Ibrahim Sbeih, speaking to you from Farah Healthcare Campus here in Amman, Jordan. And the topic for today is a spinal cord compression due to extramedullary hematopoiesis in thalassemia patient. So the title has so many titles: the thalassemia, the extramedullary hematopoiesis, and the cord compression. And the usual theme is the clinical, radiological, operative, and pathological correlation. So before we start on our case, let's discuss these items: the spinal cord compression, the extramedullary hematopoiesis, and the thalassemia. What is thalassemia? Thalassemia is a chronic anemia, and it is endemic in certain parts of the world, in the Middle East, in China, Pakistan, North Africa, South America. In fact, if you want to single one single country with the most thalassemia, it's Pakistan. And in the Mediterranean basin, in the Arab countries, in Cyprus, in Sardinia. It is an inherited autosomal recessive disorder. And it is due to a genetic defect in the synthesis of globin chain. We have 2 alpha globin and 1 beta globin. The 2 alpha globin are situated in chromosome 16, and the beta globin is situated on chromosome 11. So that's the picture. Hemoglobin is made of heme, 2 alpha globin chains, and 1 beta globin. So when we speak about thalassemia, it's either defect in the alpha globin or the beta globin, and we name the thalassemia according to the defect. So if there is defect in alpha globin, we call it alpha thalassemia. If there is defect in the beta globin, we call it beta thalassemia. So here you are. Alpha thalassemia is defect in alpha globin. In this case, it is either reduced or absent. Beta thalassemia is due to defect in beta globin. So if we speak about alpha thalassemia, it can be minor, intermediate, or major. Minor means 1 allele is mutated. Major means 2 alleles are mutated. Intermediate is moderate decrease. Here is severe decrease. So each alpha and beta are classified into minor, intermediate, and major. Beta thalassemia is the same, divided into minor, intermediate, and major, according to whether it is 1 allele or 2 alleles. So if 2 carriers, thalassemia carrier, get married, and that's why the law that you should test for thalassemia before marriage, because if you are a carrier and your wife is a carrier, then there is a chance that one of your children will have the carrier disease, and will be not affected, and 1 will be affected, and 2 will be unaffected carriers. What is the cause of this extramedullary hematopoiesis? What is hematopoiesis? It is production of red cells and white cells other than the bone marrow. And of course, it is caused by, if you have anemia, your bone marrow cannot cope with the loss of the red cells, so you look for other areas that will produce this. Male to female is 5:1. So the cause of the extramedullary hematopoiesis is any anemia which is caused by thalassemia major, thalassemia intermediate, sickle cell, polycythemia rubra vera, B12 deficiency, folate deficiency, radiation of the bone marrow, leukemia and lymphoma because they disrupt the bone marrow, myelofibrosis, and any of the hereditary spherocytosis or congenital hemoglobinopathies. Any of these will demand good production of blood products, and these cannot be met by the bone marrow, so you look for other areas. Now, in the fetal development, there are multiple organs that are involved in the hematopoiesis, not only the bone marrow in the fetus. Lymph nodes, thymus, heart, breast, prostate, kidneys, adrenals, pleura, retroperitoneal tissue, skin, peripheral and cranial nerves, brain, and spinal cord. They produce blood. But then this stops at birth, And if you have anemia, then you would cool these reserves, come back again, and produce some of the blood products. So long-standing, ineffective erythropoiesis will stimulate the extramedullary vascular connective tissue in the above-mentioned size to resume hematopoiesis, which has stopped by the time of delivery. The extramedullary hematopoiesis can be in the soft tissue or in the bone. The soft tissue is more in myeloproliferative, while bone is more in the hemoglobinopathies. Let's see the soft tissue, how the soft tissue is affected in thalassemia. We will call upon other organs, other the bone marrow and the long bones, to produce blood. These organs are the liver, spleen, lymph nodes, thymus, retroperitoneal tissue, kidneys, adrenal glands, sweat glands, pleura, prostate, spinal canal, skull, skin, heart, and middle ear. Middle ear. So your liver and spleen will be enlarged, hepatosplenomegaly, as you can see here. Liver is enlarged, spleen is magnificently enlarged, and you can see here hepatosplenomegaly. And they are producing these blood products. Here in this spleen, there are masses of hematological products, like here, inside the spleen, like here and here. So there is a blood mass within that organ, which is to produce blood. And blood can be produced in the lymph nodes, para-aortic lymph nodes, retroperitoneal lymph nodes, presacral lymph nodes. Kidneys will develop some masses on top that are going to produce blood. So they will come with kidney masses like this. This kidney produces this mass, which is this one. The suprarenal gland will also try to produce some blood, and then you'll get these masses. Suprarenal gland with mass inside it. Pleura itself, this is nodule within the pleura through the pleuroscope, and you can see that these nodules are there with pleural effusion. The anterior and posterior edge of ribs will be enlarged, like in this case. You can see at the costotransverse joint, these ribs are enlarged to produce blood. As we said, it could be in the soft tissue or it could be in the bone. So we've seen the soft tissue, let's see the bone. Usually in the vertebrae and in the cranium. There will be expansion of the bone marrow spaces, which will thin out the cortex and long bones. So if this is vertebra and this bone marrow is trying to produce blood products, it will crack the cortex and it will present into the spinal canal. As in this case here, you can see presacral mass like this. Sacrum is trying to produce blood. Skull will be thickened out. The marrow inside the skull, the venous spaces are widened. And you can see this on plain skull X-ray, so-called hair on end, as if these are hairs and they are standing up and they شعر واقف. So once again, you can see hair on end. Or enlargement of the whole skull like this. Or even bone masses, skull masses. Again, this is not fiction. These are rare cases. Like this one, skull masses. Or dural masses. This is the dura with masses in it. Or extradural mass, like extradural hematoma, but this is a mass of hematopoietic blood, or mass. Or intracranial mass inside the brain. Here it is inside the brain in the triangle. So how many cases are there in thalassemia? The incidence is not that high, it is rare to have extramedullary hematopoiesis causing cord compression. It's very rare. And I looked into the literature and I found 55 cases. Only 55 cases of spinal cord compression due to extramedullary hematopoiesis. I put it to you in this frame, starting year 54. Here, the treatment was surgery and radiotherapy. In this case, in 64, it was just surgery, and so on. So it will tell you here in 1980, these cases were treated only with transfusion and steroids. Continue the list. These cases were treated by radiation, surgery, and so on, surgery and radiation, and so on. 91. Until we reach to the year 2006, all these cases are documented. Spinal cord compression due to extramedullary hematopoiesis. And of course, flow of some of the recent applications. This case report in Oncology, 2016. Again, another case in the Journal of Neurological Disorders and Stroke. In 2017 from Japan. 2018, beginning of the year in the American Journal of Radiology. Another case also of spinal cord compression. So, obviously the treatment could be just a transfusion. We have a case of spinal cord compression and you treat it with just a transfusion, hoping that transfusion will decrease this extramedullary hematopoiesis. Or you could do surgery, or you could do just radiation, or you give cytostatic agents like hydroxyurea and erythropoietin. So what about blood transfusion? Is it good for treatment of thalassemia? Of course it is. But is it good for treatment of a spinal cord compression due to thalassemia? Some people say yes. And the advantage is that you can give it in pregnancy, in severe anemia, where you cannot give radiation or do surgery. But you have to remember that the disadvantages lie in the multiple blood transfusion that you want to give, and that would not really cure the severe cord compression. So somebody published this case of 13 patients of spinal cord compression treated by transfusion alone. 8, they had complete response just by transfusion. 5 did not have any response. What about surgery? Surgery, of course, is good. Rapid relief of the spinal cord compression. Also, you will get histopathological diagnosis. But remember, you are doing the surgery on ill patients with severe anemia, with lots of complications. Again, papers published on 15 patients treated with surgery alone. 9 had good response, 3 had no response. Radiotherapy. Some people just treated spinal cord compression by radiotherapy, and they claim that they have good response within days. Disadvantage, you don't know what you are dealing, there is no histology, and there is high risk of recurrence. This was a paper, treated their patients only with radiotherapy. 42 patients treated with the only radiotherapy. Half of them, almost, had complete response, and the other half, no response. So you could see there is no good one way of doing things. Usually it's combination of things. What about combination? Surgery and radiotherapy. 15 had surgery followed by radiotherapy. 9 had good response. 6 had no response. So even that may not succeed. Transfusion only and surgery. 3 had good response. 4 had no response. So we'll present our case now. Our case for today is this 35-year-old female patient from Jordan. It's beta thalassemia major, and we understand what's beta thalassemia. As we said, it's the beta chain or beta globin, and it is 2 alleles are affected, severe manifestations. Her story that her hemoglobin lies between 6 and 8 grams. and she had multiple blood transfusion every year. And as a child, she had splenectomy. She presented to us with 2 months history of back pain with radiation to the anterior chest wall. For the residents and in the hall, any pain in the back going anterior like this, you should be suspicious of spinal cord compression and root compression. It could be, of course, herpes zoster, but still you should think of it. And then 1 month before presentation, she had weakness and numbness of both lower limbs, right more than the left. And 1 week before presentation, she was incontinent of urine and feces. So you have the full picture of a spinal cord compression, and this patient is a thalassemia major, so it has only one diagnosis, which is a spinal cord compression due to hematopoiesis outside the medulla, outside the bone marrow. So her past surgical history, she had cholecystectomy, and this is common because these patients, due to the repeated blood transfusion and anemia, they will get gallstones, and usually they end with the gallbladder being removed. And also she had osteoporosis, the hallmarks of the disease. Her weight, she's 35, was 42 kilograms. She was ill-looking. Height is 156 centimeters, poor muscular, petite lady, pale with slight jaundice. She had scoliosis and kyphosis. She had ejection systolic murmur because of her hemodynamic state, grade 3. Her liver was enlarged 3 centimeters below subcostal margin. Of course, her spleen was removed. Otherwise, if the spleen was there, you would also feel it below the subcostal margin. And I, being a graduate of Egypt, I'm used to see a lot of hepatosplenomegaly due to bilharziasis. So we could just tell by just putting the finger on the tummy that there is hepatosplenomegaly. Mental age, she was 15/15. And in her limbs, let's look at this here, lower limbs, 2/5, 3/5 in the left lower limbs. It is not necessarily that if you have weakness or paraparesis that it should be equal. One limb may be more than the other. Since her level was at D4, she had increased clonus, let's say, and upgoing plantars. Again, hallmark of upper motor neuron lesion of a spinal cord compression. Lab studies, her hemoglobin was 7, platelets were 481, PT was increased, white PCs were 6 with reticulocytes at 4%. Hemoglobin, as you said, 7, hematocrit 29.5, MCV was 79.9, and the hemoglobin electrophoresis, as you can see, HbA1, HbA2, HbF. Serum ferritin was increased, 1,500, very much above normal. ESR was 5. Uric acid, as expected, is elevated. And her blood film showed this hypochromic RBCs with poikilocytosis and codiocytes. Viral hepatitis markers were negative. Sodium, potassium chloride were normal. But look at this, because of the hemolytic anemia and the repeated blood transfusion, bilirubin, direct and indirect, were elevated. For the preoperative images, I would like to call Dr. Athamni to comment.
Good morning. Okay. Start. This is a plain X-ray for the patient. If we move for the thoracic area, you can see here there is an medullary expansion of expansile lesion with thinning of the cortex, but there is no definite bone destruction. Also, there is a decreased bone marrow intensity in this film. Next. Coronal MRI T1 weighted. You can see there are multiple paraspinal intermediate signal soft tissue well-demarcated lesion arising from the paraspinal area, and there is a scoliosis here and kyphosis. The kidneys here looking well. Next. This is the same, but you can go back. You can see the cord here. There are multiple soft tissue lesions. Next. The same, more posteriorly. We can go more posteriorly. If you can see, there is the masses. They are well demarcated here, and there is no expansion of the neural foramen. Next. This is T2 weighted, which is very important here. If you look here, there are multiple epidural masses encroaching upon the cord and causing severe narrowing. Also, there is an expansile lesion within the spinous process here. And the bone marrow decrease here. There is no increased signal intensity, which is very important because this means if there is an increased bone marrow intensity, it means there is an infiltration, which exclude the other causes of differential diagnosis as lymphoma or something like that. Next. T2 weighted, same, the masses here encroaching upon the spinal cord, and there is no increase in signal intensity. Next. T2 weighted also. This is an epidural mass because this the CSF compressing the CSF from the outside, which indicated this is the extramedullary extradural masses. Next. This is T1 weighted. If you can see also here, the masses encroaching upon the cord, and there's no bony destruction. It's expansile lesion or no bony destruction. Next. This is axial T1 weighted, axial T1 weighted, axial T2 weighted. If you look carefully, the masses are paravertebral. There is no extension into the neural foramen, or there is no expansion from this area, which is very important to exclude neurofibromatosis. This is T2 weighted. You can see this is the cord, this is the spinal cord here, and this is the mass, encroaching upon the mass and causing severe compression. This is CT scan. If you look carefully to the CT scan, there's no destruction of the bone, just expansile of the medulla, thinning of the cortex here, and also involving the transverse process, spinal process, and costovertebral junction. This is the mass, and this is the cord. The same bone marrow, this is the bone window, the mass is here, paraspinal. Even there is a large mass lesion here, there is no definite of destruction, just expansion to exclude metastasis. X-ray axial view for CT scan also. You can see this is the mass encroaching upon the cord, the mass, very small cord here. Also, this is the cord, and this is the expansile lesion. This is bone window for the same patient. Sometimes, if you look carefully here, sometimes it might be, or someone think about aggressive hemangioma, looking over both eyes. But if you look carefully, there is also expansion of the ribs, and there is a soft tissue component. The same expansile lesion, thin cortex, soft tissue mass lesion encroaching upon the cord here, and this expansion of the costo and cervical and transverse process. Bone window, the same. This is the mass. There's no cord here. Next. The same soft tissue component, extramedullary arthrobiasis. This is the liver is large, and the spleen is absent due to surgery. I think the density of the liver is increased here. Next. Liver enlarged, no spleen due to splenectomy.
Thank you, Dr. Atamna. Any of our radiologists, any comment? Okay, we'll proceed. Anesthesia, announced patient shoot for general anesthesia. We got the necessary consent. And we stated here that the aim of surgery is to decompress the cord and not to remove all the tumors or the masses, because this is the disease itself. It is due to the thalassemia. So I don't have the video to show it to you. I looked for it. I could not find it, so I'll just tell you what we find. We did laminectomy, T6 to T10 inclusive, and we found large vascular extradural mass as expected. So this is the laminectomy. This is the mass extradural. And just like a clotted blood, but a little bit elastic and more solid kind of thing. Pathology, Dr. Hassan Hanab, please.
I'm not sure, is this my case or it was the Musa Abadi case? Yeah, so I'm just presenting the case. So, okay, so this is from the paraspinal mass, and you can see there is bony trabecular here, and this is the bone marrow, which is extremely cellular and almost 100% cellularity. And at this bar, you can see that there are some megakaryocytes, and these are the other hematopoietic cells. Okay. This is higher bar. You can see that this is trilineage hematopoiesis. Megakaryocytes here. These dark cells with small round nuclei are the erythroid precursors, and the larger cells with lighter staining nuclei are the myeloid precursors. Same thing, these are the erythroid, myeloid, and megakaryocytes. Same thing here, you can see that this is trilineage hematopoiesis. And again, very cellular bone marrow with all three hematopoietic elements present. I think that's it, the same. This is oripity, but you can see here, yeah, you can look here. These are the immature myeloid series, and these are the megakaryocytes. So, yeah. Okay. I think that's it. I just want to mention that usually extramedullary hematopoiesis presenting as paraspinal or whatever tumors is more common in actually thalassemia intermediate, because these are less dependent on transfusions, and transfusions will suppress extramedullary hematopoiesis.
Dr. Ala, would you like to comment?
Morning. Extramedullary hematopoiesis is an extraordinary manifestation of, and a very interesting manifestation of thalassemia generally. In adults, you would, when you get issues with extramedullary hematopoiesis, for patients who are not known to be harboring hemoglobinopathy like thalassemia, you would think of any process really infiltrating the bone marrow to an extent that you really need an extra site of production. The classic example on this is in adults is primary myelofibrosis. And the old joke of if you really want to have a boring exercise and differential diagnosis, the question to be to the students, in which organ can you get extramedullary hematopoiesis and primary myelofibrosis? And the short answer to that is basically any organ in the body can get extramedullary hematopoiesis as a harbored site of production in a process like primary fibrosis. In patients with thalassemia, the usual sites for that would be the liver and spleen, and hence the hepatosplenomegaly that you're going to get that, and that's mainly in thalassemia major intermediate that they're going to get enough blood transfusion. Intermediate will get less blood transfusion, and therefore they may be more prone to this. But again, in thalassemia major, despite all your attempts to suppress the extramedullary hematopoiesis with chronic blood transfusion regimens, you may not be able to do that. Now, there's a very big spectrum of the severity of thalassemia major. So this lady had thalassemia major by the hemoglobin, this patient had thalassemia major by hemoglobin electrophoresis. But as you've seen in the history, the transfusion was needed once a year. In that bracket of thalassemia major, you can get the patient can be transfusion dependent to an extent of once every month or so. And I cannot emphasize enough the importance of being very cognizant of the iron overload you're going to get as a consequence. And these patients are on chronic chelation, iron chelation therapy. And a lot of the long-term complications of thalassemia are related to the iron overload. Now, luckily, we have better agents for iron chelation, but the major issue with iron chelation is the lack of compliance with patients with long infusion or sub-Q preparations like this fluoxamine, etc. Now, the diffuse nature on the images that you've seen is more suggestive of that diagnosis, but you always have to bear it in mind. In a lot of times, you're going to get a discrete lesion that's going to be difficult to discriminate from other lesions in that part of the world, and it's only by surgery that you can actually get a tissue diagnosis. The blood transfusion to which that was alluded to earlier, we really need time to suppress the drive, but in a lot of times thalassemia major patients, the drive is so intense, blood transfusion in the short term is not going to do anything to relieve something as acute as a cold compression, as was clearly illustrated in this case.
Thank you. Dr. Adnan Abrajab, would you like to comment?
No, thank you.
All right. Dr. Jarir, do you see lots of thalassemia in Jordan?
Yes. Yes.
And Dr. Muntasir?
Yes, sir.
Any comment?
No comment.
All right. Anybody want to
Except,
comment?
if I may,
Please.
what Ala referred to as the iron load and overload, to us that encourages bacterial and fungal infections, in particular mucormycosis. Mucor tends to love iron, so we'll keep that in mind in these patients.
Surely. For Ziad Zabi, as a spine surgeon, have you seen cases of spinal cord compression due to extramedullary hematopoiesis?
One case actually, but my comment about this case, you did laminectomy from T6 to 10,
yes.
Right?
Yeah.
Okay, this is actually the maximum kyphotic, normal kyphotic spine or dorsal spine. And doing laminectomy, this osteoporosis may lead to more kyphosis, and even because she has also some scoliosis. So it may actually, this scoliosis and kyphosis will progress due to osteoporosis and due also to the loss of the posterior stabilizing factors like spinous ligaments and spines. So it would be nice actually if, the bone taken from the laminectomies, from lamina and spinous process to be implanted on the reps beside with some augmentation of cancellous sponges.
So it's like a hemilaminectomy or laminoplasty. Okay. Any other comments?
I may ask Dr. Muntasir.
Sure.
Dr. Muntasir, we see a lot of thalassemia in this country, obviously for clear reasons. Do you see a lot of mucormycosis in them?
We don't. I personally have not seen that, but it is a risk factor in the literature that an iron overload, much like diabetic ketoacidosis, is a risk factor for mucormycosis.
Because that's a very intriguing comment. Now, because of that association to which you've alluded, I'm actually surprised why we don't see more, because we definitely see a lot of iron overloaded patients. I wonder if the site of overload is an issue, reticular endothelial as opposed to elsewhere.
Yes, it might be that. In addition, it might be the other comorbidities as far as immune suppression might be. So might be just a factor, and others are needed to cause enough immune suppression for mucor to invade, such as DKA or HIV or etc.
Dr. Haitham Azam, you wanted to comment?
Regarding the differential diagnosis, it is when the disease is like this, the differential diagnosis is narrow. But when we have one or single or two masses, then neurofibroma may be considered in differential diagnosis. The second is when the kidneys are involved. Usually we have enlargement of the kidneys, and in ultrasound we find that there are echogenic kidneys. Sometimes if it is single kidneys involved, then differential diagnosis is narrow also. But when two kidneys are involved, then lymphoma should be considered in differential diagnosis, because lymphoma is almost always bilateral and not single. Thank you.
Well, with all due respect, we do see unilateral involvement of kidneys by lymphoma. Renal involvement lymphoma is an extremely uncommon event. It can be secondary, as you very well know, to other systemic manifestations of lymphoma. Primary renal lymphoma is a well-characterized rare extranodal lymphoma, and a lot of those, the extranodal lymphomas in the kidney tend to be unilateral. There's this, since we are in a neurosurgical meeting, there's this continuous controversy whether renal involvement by lymphoma constitutes a risk factor for CNS involvement or no. And this controversy still rages to this day. I have also to emphasize the fact that actually kidney involvement by extramedullary hematopoiesis is a well-characterized form as well. Now, if I may ask my radiological colleagues, since we're talking about thalassemias, we really have problems of quantifying iron in this country, in iron load in this country for thalassemic patients or otherwise. And a lot of the radiological techniques we were used to perform in the States are not really available to actually quantify iron radiologically. And I wonder if hopefully I'm mistaken and there's something new that we can do. So if I want to quantify iron in the liver MRI, in which protocol would help, etc.
I saw the histological pictures, and it looks to me the megakaryocytes are really abnormal, and you wonder whether this is myelofibrosis-like picture in thalassemia, in a higher power that not this one. Yes, that in these areas, I think these are most of them are megakaryocytes. Yeah, this in the bottom are megakaryocytes. And there is some studies about JAK2 inhibitors that should be treated in these patients. So this is a new treatment modalities in extramedullary hematopoiesis in thalassemia that we should consider, because some of them may have JAK2 mutation on top of the thalassemia, and they may improve on JAK2 inhibitors as a new type of medicine. And you know, there are extramedullary or myeloproliferative disorder, there are more than JAK2, there's like calcridin and other inhibitors that can be used in thalassemia.
Dr. Ala, through the question to the radiologist, do you have any way of quantitative measurement of the
in Jordan, not international, because we know what's international?
Yes, there is a sequence now in GE. It can quantify the iron in the liver.
Okay, and that's
yes,
available.
It's not applicable nowadays because just in GE.
Ahmed,
you can quantify it. Yes.
Any comment on this?
No.
Any radiologist to comment on this? Okay. I'd just like to ask the audience about what is the current situation in Jordan regarding interfamily marriages. To, you know, if somebody wants to get married to his relative, Is there a law in Jordan that decide that you go and test for thalassemia?
Well, there's a law that thalassemia tests should be offered in premarital for any marrying couple. The limitations of this are actually numerous. One is that they're only testing for beta thalassemia, as if this is not a country that has alpha thalassemia in it. Two, this is not really done in a context where there's family counseling to that. So basically, they just need a certificate before they get married. Now, the implications of these are tremendous, because what usually happens, and I see a lot of these referrals in my clinic, is that a couple are getting married and one is harboring a thalassemia trait that was incidentally found on the pre-marital hemoglobin electrophoresis. And the other partner is known. And you could have actually guessed about the trait just by looking at the CBC and the blood film. And nobody actually looked at the CBC and the blood film. There's no hematologist or a good internist to actually look at the CBC and say which test to be ordered. And usually the patient comes to my clinic freaking out, oh, I have thalassemia, and they're harboring a thalassemia trait with a normal partner. Now, the issue is if they have a thalassemia trait and the partner is having a thalassemia trait, the problem is that you actually can get a thalassemia intermediate or minor in the offspring. And the other problem is you can't actually predict necessarily if one of the patients, the parents have thalassemia intermediate, for example, the severity of the manifestation in the offspring. But so the other problem is that despite the fact that there is a law to enforce that testing, there's absolutely no idea what to do with it. So there is actually nothing to prevent two thalassemia major parents from getting married. Now, it's actually unethical to prevent two thalassemia major patients to get married. But the unethical thing is for two thalassemia major patients, or one thalassemia major patient to get married and stresses or refuses the whole options of contraception. So they insist upon procreation even if the two couples are thalassemia major patients, which is absolutely ludicrous. Now, of course, this is a hypothetical scenario because usually two thalassemia major patients are not going to be able to conceive normally because of the iron overload issues. So this is basically the unfortunate background to this scenario.
Dr. Muhammad Hassan, as a spine surgeon, do you see these cases? Okay.
So did I get it that it is not mandatory to have the test?
No, it is mandatory to have the test, but there's absolutely no logic about what to do with it.
Okay, we'll proceed and see what happened with our case after surgery. But of course, she showed remarkable improvement because we interfered at the right time. And that surgery is the best solution in these cases if they have severe spinal cord compression, like in our case. So she improved dramatically, the sensory level disappeared, the incontinence disappeared, and she was able to walk. And these are the post-operative images. You can see the cord totally free. No cord compression, that's the cord. And this is before and this is after. Here there was extradural compression, here there is no cord compression. We followed her up for 5 years. Again, of course the lumps are still there, the disease is still there, but there is no cord compression. And we continued for 8 years. At that time, she developed recurrent symptoms of cord compression. Back pain, limb weakness, but not in a severe way, no incontinence, the weakness was mild. And that's her pictures then. At that stage, and because the cord compression was mild, we referred there for radiation therapy, which he had. And this is the report from Dr. Abdulatif Al-Musa at King Hussein Cancer Center, the above-mentioned patient, in one case of thalassemia major with dorsal soft tissue mass. Planned received palliative course of radiotherapy, 18 rays over 12 fractions during 19/2 to 6/3/2007. Patient tolerated treatment well. Followed up for 12 years, 2012. And she was still anemic, of course. She died 17 years later, 2017. She was 52 years of age at the time of her death because she succumbed to her disease, which is usually the case. Do they live long? Thalassemia is major?
Thalassemia majors, unfortunately, don't live long, and that's usually because of ill attention to the long-term complications of that. The major issue is the attention to the iron overload they're going to get. The major issue are the best the management of the transfusion protocols early on. These strategies are implemented early on in the life to prevent the late complications and to prevent early deaths. I have also to emphasize that this is more of an issue in thalassemia major. In thalassemia minor, these patients have just this lab abnormality. And back to the question about the testing that Dr. Montasser was asking, it's one issue of the test is the label these patients get. So thalassemia minor, the patient will get a label of thalassemia. And for patients who actually don't know anything about the disease, they just get this label, which actually means absolutely nothing except you don't necessarily you have to be cognizant of the fact that two thalassemia minor patients may have a different manifestation of their offspring. But hence the discussion about the iron overload. A lot of the long-term complications are iron overload related, unfortunately.
Dr. Adnan, what's your experience with these cases?
Well, regarding your question whether they are surviving or not, or no survivor, really nowadays the overall survival is getting better with successful bone marrow transplantation.
Okay. So you think bone marrow transplantation changes?
It's one of the indications. But my question, excluding the cases who have acute symptoms and need surgery, excluding this group, what you, in your opinion, what is better? To do surgery alone, radiotherapy, or combination of both?
I'll answer this with the last slide. So, because it is a rare case and we looked it up, we published the case. And this case was published in the Pan-Arab Journal of Neurosurgery under the same title, spinal cord compression by extramedullary hematopoietic tissue in a patient with beta thalassemia. That's myself, and these are all my residents. It was actually on the cover page of the Pan-Arab Journal. And this is the paper. Again, I'm trying to emphasize the importance of publication, which is almost zero in the Arab world, which is a pity that we don't encourage our juniors to do that. As I said, in every interview you do abroad, there is one question that you are asked, definitely. Have you participated in any research or paper publication? If the answer is no, your interview finished there and then. So you have to think of doing research. The material is there, you just have to be active and study it. We cited lots of references. And I don't believe in those papers with 3 or 4 references. They're lousy. Nobody would look at them. We cited something like 62 references for this. So in conclusion, and this is to answer Dr. Adnan Ibrahim, what would one do when one faces a spinal cord compression due to extramedullary hematopoiesis in thalassemia patient? First of all, if the hemoglobin is less than 10, most likely you will need blood transfusion. And then you look at the symptoms. If there are mild spinal cord compression, meaning minor weakness, no incontinence, no sensory level, then you can start with radiotherapy. If the cord compression is severe, like in our case, paraparesis, grade 2/5, sensory level, incontinent urinary feces, there is no time to give for radiotherapy. So you go for surgery. And you have to follow them every 6 months for life, because they may develop recurrence of their symptoms. With this, I finish. If there are any questions or comments, please do. Please.
The consistency of the mass.
Yes.
Is it bloody? Is it hard? Is it soft? What it is?
Yes, it is soft, but not like a blood. It is jelly-like. It's just like a hematoma, but more elastic, more firm. And you can easily take it off. It is one of the easiest surgeries because you just take the bone out and then you just push this tissue out as it is. So it is not a difficult surgery, but it is difficult to treat in terms of the disease itself. Please, Dr. Jensen.
Look, regarding, the time of surgery, probably you should not wait until the incontinence happens.
Sure, absolutely.
Weakness is enough, and sometimes, risk factors regarding incontinence, like frequency or, just a drop of water which is coming on its own is enough. Because if you wait till incontinence, in so many cases, this is not recovered.
Irreversible.
So that's very important. Regarding the time of surgery, whether due to thalassemia or due to this protrusion or due to any reason. I have seen so many doctors waiting till the end of or the patient himself actually, because he's scared of surgery and complications of surgery. They are waiting till the incontinence become complete, which is not actually.
True. Very good point. Thank you. Any other? Dr. Hassan?
I want to talk about the screening for thalassemia, premarital screening. Actually, Ministry of Health will ask for the MCB on CBC. If it is normal, they will not do anything else.
Is this enough?
Most of the time, it is enough, yes. Because they are strict, actually. Even MCB of 78, you have to do electrophoresis.
So just
even if you do electrophoresis, sometimes you will not pick up the cases because some of them will be silent gene, which means that he is carrying the thalassemia gene, but the electrophoresis will be normal in this case, and you report it as normal. I have had one experience with a couple who came back to me, and there was both of them, they had thalassemia minor. They went to they can marry, actually. They cannot stop their marriage. But what they will do is they will ask them to sign
consent
that if the government will not be responsible for treatment of their offspring. So this is the catch.
No comment about hemoglobin electrophoresis. In thalassemia minor, we depend on the high A2. If it is more than 3.5% of the total hemoglobin, this is considered in a patient with MCV low, that this could be thalassemia minor. But unfortunately, in many women, iron deficiency can decrease A2. But if you have patient that is supposed to be 5 in A2 تاعتها, وعند iron deficiency, it may go below 3.5. But we can mask that she has thalassemia minor when we do the hemoglobin electrophoresis, and we can treat her or consider her as not thalassemia minor. So hemoglobin electrophoresis, iron deficiency can mask the percentage of E2 and decrease it, while thalassemia minor should increase it, and that's why some cases will escape detection, and especially in ladies that menstruating and they have iron deficiency. So you have to do iron or ferritin for them to make sure that they're not low in ferritin when their A2 is about in the borderline range.
So traditionally, when residents ask for CBC, complete blood count, is this enough?
No.
It's not.
The single most important test is actually the blood film to look at what you're talking about.
How often people ask for blood film? Very important.
Well, the mismanagement, the routine mismanagement of things in the country is extraordinary. I have to emphasize here a few things. CBC alone without looking at the blood film is meaningless. Commenting upon MCV, MCH without commenting upon the RDW is meaningless. Another meaningless maneuver that unfortunately is very common is that ordering iron without ordering the total iron capacity and ferritin, which is extremely common. Another disastrous mistake is that seeing a low MCV and low iron without doing TIBC and ferritin, and assuming the patient is iron deficient, and routinely giving iron replacement therapy. And some of these patients are actually thalassemia traits, and they're on iron forever with absolutely no reason. The thing is, thalassemia minor patients actually are less prone to getting iron deficiency. They can still get iron deficiency, but they're less prone because the whole metabolic system, their absorption of iron is higher than the normal counterparts. And therefore, true iron deficiency definitely can happen, as Dr. Hussam has beautifully alluded to. But the thing is, true iron deficiency is actually less common in age-matched individuals with thalassemia minor because of that. Because this is a very common mistake. Somebody with low iron, without doing total iron capacity, and without doing ferritin, without looking at the blood film, and they're iron for life, and they're thalassemia traits. This is criminal. Not to mention treating iron deficiency without knowing the cause and non-menstruating.
Jareed, I'd like to hear your opinion about pediatric population of thalassemia. How often do you see them? What do you do with them?
I'm happy to say that we are having these problems of spinal and all these things after the age of for pediatrician to be seeing, But things as mentioned, the bone marrow transplant changed the whole thing. We used to see people dying. That we had so many transfusions, and I had quite a few patients that had bone marrow transplantation, and they got married, and things are all right. But we used to see a lot. We don't have all these special ways of avoiding complications of transfusion and so on. But at my time, we used to see every day there was a thalassemia patient in my clinic. Thanks God, I don't see anymore.
Because you stopped seeing them, not because they went away, right?
No, because they did this test, when you were my patient, I think your mom knew that we did what I need to do, make sure that your siblings will not have, they had to have the blood test. Siblings.
And I'm not a carrier of
brother and sister and so on. They were my patients too.
Of course, not to brush aside the immediate mortality of transplantation, which is getting less with time, but patients can still die of transplantation that is done to prevent the delayed death of thalassemia. This is one of the issues about transplantation generally.
Ala was a patient for Dr. Jareed. Dr. Mamoun Klub, have you seen cases of neurological manifestations of thalassemia?
This is my first ever case. I remember in Jordan, we don't see thalassemia a lot in the States. So this is very interesting.
Thank you.
I had never seen a thalassemia as my lab.
Where were you in the States? Where were you based in the States?
Medical College, Wisconsin.
So in Wisconsin, I was in Minnesota, so that's actually less of an issue because the population is Swedes, Norse, as opposed to people who practice in California, where there's a lot of Southeast Asians and Middle Eastern people on the Senate. And the pockets of New Jersey, where there's a lot of Middle Easterns as well. So it really depends upon where you are. Definitely in the northern Midwest, with the Scandinavian descent of the population, this is less of actually an issue. You see more of hereditary hemochromatosis than secondary iron overload because of this.
Dr. Naseem Abdul Qadir, as cardiologist, do you see such cases? No. There's a question there.
كان one mother transfusion prevent the progression of minor spinal compression. Second question.
You mean you will do bone marrow transplantation as a treatment for spinal cord compression?
Yes.
Transfusion or transplantation?
Transfusion or transplantation?
Transplantation.
Transplantation. So this is not on, because you will not do transplantation of patients with a spinal cord compression. You will either go for surgery or you go for radiotherapy.
It's not an option.
No, it's not an option. What's your next question?
Regarding the MCP, do you mean that if we have a normal MCP or a high level of MCP, still we have to think of thalassemia, major or minor?
MCV alone is a meaningless test without putting it in context. So you can have a normal MCV with a high RDW, which means that you have a biphasic population, and you can still have a low a population with that is microcytic and can be also hyperchromic. So MCV, when you comment upon MCV, you have to comment on the MCH, MCHC, the RDW, and you have to look at the blood film. Saying an MCV alone means nothing. Having said that, I have to say that thalassemias usually have a narrow RDW and low MCV unless there's something else going on. And as we have alluded to, it's unusual for thalassemia patients to get iron deficient. But thalassemia patients, thalassemia minor patients at least, they can still get iron deficiency, which is uncommon. But commenting on MCV without commenting on the MCH, the MCHC, the RDW, and looking at the blood film is one of the most common manifestations of malpractice in the country. Like ordering iron without ordering MBC.
So as you're here, what would you tell the junior staff? Should they just write CBC? Is that enough? Is this word enough? Or should they elaborate on this?
If I want to give you whenever a hematologist asks you a question about the next step, 99% of the time, the next step is going to be a blood film. And the 1% remaining is going to be blood film with something else at the same time. So looking at blood film is actually part of, in heme wards, looking at the blood films is part of the rounds. You actually go down and look at the blood films of every single patient on the ward, particularly when you have wards with a lot of leukemias. And
you mean doctors or the lab should look at the blood films?
I mean doctors. I mean the doctors assigned to the patient. You go, you round on the patients, and then you go down to the path, you round on the blood films. You actually look at the blood films. And the practice of throwing the blood film in the lab 3 days later, like some labs do in this country, is absolutely pathetic. You keep the blood films for at least the routine blood films done for at least a month in respectable labs before, particularly in the inpatient setting. And I'm talking about the routine smears done daily. I'm not talking about the blood films asked specifically for a specific diagnosis where these are left in the lab forever, filed forever. So you look at blood films as part of your runs. Absolutely.
As a pathologist, one comment on the MCV. The MCV can be falsely normal when you have hemolysis, and that can get you macrocytosis beside microcytosis. And when you measure the apparatus, when you measure the machine, measure the MCV will give you normal. So you have to look, the pathologist has to look at the blood film, and sometimes you have to measure to do reticulocyte count. Very important to do reticulocyte count sometimes. Sometimes when I look at the blood film, I order myself reticulocyte count. If there is an increased reticulocyte count, you have to change everything according to the number of reticulocyte count. And folic acid measurement sometimes is needed in these cases.
There is a song I remember as a youngster. It was called Once Upon a Time There Was a Tavern, which means the days we were, or the days that gone by. These days are gone by. The doctor in training, and I was to be one of them, in London we had to do the blood gases ourselves. We have to take the arterial blood and go to the machine and do the blood gases. We had to do the blood film. We had to do urine culture, urine routine, smear, etc. Stain. Yeah. So where are those days? Why are these young generation not doing them? So we have to be careful. I'd like to thank you all for coming today. And next week we'll have a very interesting case of trigeminal schwannoma. And we'll discuss the case presentation and the types of schwannoma. It's a skull-based surgery. It's very interesting, very rare. Thank you very much.